like to thank everybody for coming to Hiral's dissertation defense. So I'd first like to acknowledge Hiral's committee members, Lynn Snyder-Mackler, Greg Hicks, and we have Michael LaValle from Boston University online, as well as Monica Malley from the University of Waterloo. Hiral has had quite a journey. She started growing up in Mumbai, India, and she got her BS in physical therapy from Seth GS Medical College in 2011. Then she got a master's in physical therapy from R.U. Gandhi University of Health Sciences in 2013. Then she took a little plane ride and went to the University of North Texas, where she received a master's in public health, and certainly around the time she was graduating, sent an email to Lynn, who pulled me aside and said, hey, we have this student, and she sent me an email, and you should look into bringing her on. And I was just starting as a faculty member then, so that's when I somehow convinced Hiral to come here and study with us. So Hiral has been incredibly productive while she's been here. She has been the first author of one publication and just submitted another one over the last 48 hours. And she has 4 co-authored peer-reviewed papers in addition to that. She wrote a letter to the editor and has been the lead author on 8 conference abstracts, predominantly most of which were platform presentations. And she's given 2 press conferences at these conferences as well. She's been awarded and acknowledged for the work she's done as a doctoral student, and just some of the highlights from that is she was the outstanding graduate student in rheumatology in 2018 from the American College of Rheumatology. She's a member of the Honor Society of Phi Kappa Phi, of which I looked that up. Jimmy Carter is a member, and as is Al Gore. So that was interesting. She is a Unidel Foundation. She received the Unidel Foundation University Doctoral Fellowship from the University of Delaware, as well as a summer doctoral fellowship. So anyways, Hiral, we look forward to listening to your dissertation defense, and the floor is yours.
Thank you. Thank you so much, Dan. So thank you everyone for coming on Friday afternoon for my defense. My defense, or my dissertation, is basically investigating the predictive value of performance-based physical function measures for OA-related health outcomes. And as you see, these are my committee members. So osteoarthritis is a serious disease. Why is it a serious disease? Because worldwide, over 250 million adults aged over 50 years have knee osteoarthritis. So what does this 250 million adults mean? It is approximately 4 times the population of United Kingdom, and this population is expected to grow by over 50% in next 20 years. So what that means, 130 million additional people are going to get knee osteoarthritis. So that is equivalent to the population of Japan. Unfortunately, this disease has no cure. Even though it's such a serious disease, there is no cure found till date. Further, knee osteoarthritis is a leading cause of function limitation. So function limitation represents restriction in performance of specific tasks by a person. And by 2050, worldwide, 1 in every 3 people with knee osteoarthritis will have severe function limitation. So function limitation, some examples of function limitation is difficulty crossing the street. So it can be quantified by slow walking speed. And I'll refer to it as slow walking speed in the rest of my presentation. The second example of function limitation is difficulty getting up from the chair. And I'm going to refer to it as limited repeated chair stands. Fortunately, this function limitation can be addressed by rehabilitation. However, rehabilitation is underutilized. And most commonly, people would think, oh, drugs and injections will take care of my pain. But unfortunately, it doesn't take care of function limitation. And if function limitation is left unaddressed, it can lead to OA-related health outcomes. I'll discuss OA-related health outcomes when I will go in for each of my specific aims. So what we can conclude till now? We can conclude that assessing functional limitation is very important and it may be helpful or it may guide the care for this patient population. So just like temperature, when all of us must have had fever some point of their life, and we all went to primary care provider or physician. A physician decided what needs to happen by assessing the temperature. So thermometer is a valid tool to assess temperature, and a clinical thresholds on this thermometer can guide the care of, so if at all someone has 100-degree Fahrenheit fever, then probably they have mild fever and they will just need medication. As opposed to someone who has 104-degree Fahrenheit fever, then that's like really severe or high fever, and they would need hospitalization or advanced treatments. So applying the same logic for functional limitation. Here, the vital sign is functional status, like walking speed or repeated chair stands. Fortunately, we can assess this functional status by valid and reliable performance-based measures. I'm going to talk about performance-based measure when I describe my methods. However, the thresholds or clinical thresholds, meaningful thresholds that can guide care for this patient population is unclear. We do not know what thresholds are bad. Therefore, this is a conceptual map that I'll be using for the rest of my dissertation to present my dissertation. As mentioned, there are two functional vital signs that I'm interested in my entire dissertation. The first one is walking speed, and the second one is repeated chair stands. So I was interested in walking speed because walking speed can be measured by performance-based measure, and if performance-based measure indicates someone who has slow walking speed, then it tells that there is impairments in lower body muscle strength, aerobic capacity, postural control. All of these impairments can be addressed by rehabilitation. So, walking speed is considered as a functional vital sign in well-functioning older adults, mainly because it predicts current and future health outcomes. So, someone who is walking less than 1.2 meters per second have difficulty crossing streets using time signals. If someone is walking less than 1 meter per second, then they have increased risk for hospitalization and all-cause mortality. However, it is possible in real-world clinic that a physician or a healthcare provider may not have a space to measure walking speed. In that context, maybe there's a need for an alternative functional vital sign. Therefore, in this dissertation, I was interested in investigating repeated chair stands as an alternative functional vital sign, mainly because repeated chair stands is known to predict future health outcomes in older adults and in patients who have stroke. So someone who takes more than 12 seconds to complete 5 times sit to stand have higher risk for falls. Someone who takes more than 15 seconds to complete 5 times sit to stand have higher risk for recurrent falls. Unfortunately, we do not know how well this functional vital sign predicts OA-related health outcomes. Why should we investigate this? Investigating this is very important because if functional vital sign is predictive of OA-related health outcomes, it can say, oh, this person with knee osteoarthritis have functional limitation severe enough that they are prone to poor health outcomes. It can also guide clinical decision making. So it can tell healthcare providers like physicians, surgeons, what they should be using, like drugs, injections, rehab, what for knee osteoarthritis. It can also help physical therapists to tailor and track their rehabilitation program. This brings me to my study purpose, which is to study the predictive value of performance-based measures that is used to assess functional vital sign for OA-related health outcomes. These are my aims. Don't worry, this slide is very wordy. I'm going to explain it by figures when I explain my each aim. So aim 1. So my aim 1 is to investigate functional vital signs, that is walking speed and repeated chair stands. How is it associated with physical inactivity? Why worry about physical inactivity? Worldwide, 5.3 million can die because of physical inactivity. And people who are inactive, they can face cascade of health problems such as cardiovascular disease, cancer, diabetes. Further, people with knee osteoarthritis who walk less than 6,000 per step who walk less than 6,000 steps per day have higher risk for functional decline over 2 years. What we hypothesize is pre-existing functional limitation may preclude individuals' physical ability to engage in active lifestyle. It's like someone telling me to lift 200 pounds in CrossFit. I can't do that because I don't have physical ability. But that doesn't mean I cannot ever do that. I just have to build my physical ability to lift the RX, to do the RX workout. Right now I do scale workout, which is bad, but getting there. Further, we do not know whether functional vital signs assessed by performance-based measure predicts inability to engage in an active lifestyle. Therefore, the study purpose of my aim 1 was twofold. First is to investigate the association of functional vital sign with physical activity, where physical activity was a continuous measure, that is steps per day. And second was to investigate a minimum performance threshold on this functional vital sign to reach at least 6,000 steps per day. We choose this threshold because this was important threshold for knee osteoarthritis. Hypothesis, I hypothesize that slow walking speed is related to walking fewer steps per day, and my second hypothesis is limited repeated chair stands would be associated with walking fewer steps per day. So for the methods, I'm going to discuss the methods, and these methods are consistent for aim 1, aim 2, aim 3, and aim 4. So all my aims are basically that I'm going to present in this presentation. Like I've done like little randomized controlled trial studies too, but for this purpose, I'm only going to present the findings from secondary data analysis of an observational study, which is Osteoarthritis Initiative Study. So OAI is a prospective observational cohort with annual clinic visits, and adults aged 45 to 79 years old who had knee osteoarthritis or who had risk for knee OA were recruited in this study. Recruitment happened from 4 clinical sites, that is Maryland, Pennsylvania, Rhode Island, and Ohio. IRB approval was obtained from all OAI sites. And we also approved like exam from IRB, so it was all IRB approved. Then this study had a 9-year follow-up data. So very rich data set. We had 5,000 participants and they were followed up for 9 years, so great data sets. For my functional vital sign, that is walking speed was measured using a 20-meter walk test. So participants were told to walk at a usual pace over the 20-meter walkway, and the timing was recorded using digital stopwatch. Walking speed was then calculated by dividing the distance, that is 20 meters, by the time taken to complete that 20-meter walk. This 20-meter walk test has high test-retest reliability in adults with knee osteoarthritis. The second functional vital sign was repeated chair stance, which was measured using 5 times sit-to-stand test. So in this test, the participant is told to cross their hands across their chest, and they have been told to get up from the chair and then sit down for 5 times consecutively. Timing is again done by digital stopwatch, and this test is known to have high test-retest reliability. For my aim 1, my first outcome was physical inactivity, which was quantified using steps per day. So the study measured steps per day using uniaxial accelerometer, which is a device which is worn over the right anterior superior iliac spine, and it is a valid and reliable device to record free living physical activity. We only included participants who wore the monitor for at least 4 days and for at least 10 hours each day. We used this criteria because this was a minimum time required to estimate individuals' physical activity. We then classified participants who were inactive if they walked less than 6,000 steps per day, and as active if they walked at least 6,000 steps per day. So before I go into the statistical analysis, I'm not going to discuss the methods and the results in depth because this aim has been published and has been presented multiple times during my stay over here as PhD student. So I'm not going to go over. So just for my purpose 1, we use multiple linear regression model to investigate the association of walking speed and repeated chair stands with steps per day, and to investigate the minimum threshold for walking at least 6,000 steps, we use high specificity. So going to my results, what happens is So these are my effect estimates that I pulled up from multiple linear regression model. What it says is walking 0.1 meter per second slower on a 20-meter walk test was associated with walking 342 steps fewer per day. And this result was statistically significant. Second is taking 1 second longer to complete 5 times sit-to-stand test was associated with walking 130 steps fewer per day. Again, all the effect estimates were adjusted for potential confounders like age, sex, education, BMI, and race. Therefore, my hypothesis for AIM-1 was supported, that is, walking speed and repeated chair stands were associated with physical inactivity. So this study provided a preliminary this study provided that physical function was associated with steps per day, and it also gave thresholds of the functional vital signs needed to walk at least 6,000 steps per day. What we found that walking the range of thresholds, so we found walking speed between 1.1 to 1.2 meters per second was a range that was predictive of walking at least 6,000 steps per day. And the range on 5 times sit-to-stand test was between 11.4 to 14 seconds. These thresholds were consistent with previous literature, which were predictive for poor health outcomes like difficulty in community ambulation or higher risk for falls. However, there are some study limitation. We only tested for one cutoff, that is 6,000 steps. Second, we used steps per day as a marker of physical activity. So it is possible that we may have missed activity which requires no steps, like gardening, swimming, biking. Third, we did not use any intensity variables. And lastly, this is a cross-sectional study, so we cannot infer causality. So what it comes, like the clinical implication of this AIM-1 was, consider referring patients with knee osteoarthritis for rehabilitation if they do not meet these thresholds. Because what this threshold says, that walking speed less than 1.2 meters per second or repeated chair stands more than 12 seconds, what that implies? It implies functional limitation and requires, and these patient requires rehab to assess the underlying impairments which is causing this functional limitation and then treat it. The study was published in Arthritis Care and Research Journal and had received some media attention, so it was kind of like cool. Now I'm going to my AIM-2. So AIM-2 is, we were interested in investigating the association of walking speed and repeated chair stands to knee replacement. Now the reasons I'm looking for investigating these different health outcomes is to see how well this functional vital signs, how robust are they. Therefore I'm interested in looking at different health outcomes. So why knee replacement? So knee replacement is an elective surgery, and it's, what I mean by that is, people with knee osteoarthritis choose. It's not like an emergency procedure. They choose whether to go for it or not go for it. This surgery is projected to grow by 673% in United States of America. What I mean that 450,000 TKRs were done in 2005, and by 2030, over 3.48 million adults will undergo would have knee replacements. This increase in knee replacement in turn has a huge implication in healthcare costs. Further, cartilage loss and radiographic severity is not known to fully identify the risk for knee replacement. Mainly because structural impairments do not always correlate with symptoms and function limitation. What I mean by that is, if patients have severe radiographic impairments which can be shown, which can be seen on X-ray, and if they do not have pain, they will not undergo surgery. They will not do surgery. Therefore, this is what I mean by this statement, that structural impairments do not always correlate with symptoms and function limitation. Currently, there are no well-established approach that predicts the need for knee replacement, which incorporates knee health as well as function. Now, we know that slow walking speed predicts poor joint health and predicts worsening of depressive symptoms in adults with knee osteoarthritis. But we do not know if this walking speed or repeated chair stands can predict the future risk for knee replacement. If it can, then probably we can identify these patients earlier and maybe we can delay the surgery. Therefore, my AIM-2 was to investigate the association of functional vital sign with knee replacement. My hypothesis was same, slow walking speed and limited repeated chair stands would be associated with higher risk for knee replacement. I'm not going to discuss the methods because it's similar to AIM-1. My outcome, this was time to knee replacement, which was quantified from baseline visit date to the date when they received knee replacement during the course of study. The course of study was 9 years follow-up, so they could have received knee replacement anytime during the 9 years follow-up. The date of knee replacement was adjudicated using medical records. For the statistical analysis, we examined the association of dysfunctional violence sign with the risk of knee replacement over 9 years using Cox regression model. Specifically, we calculated hazard ratio and 95% confidence interval, and we adjusted our models for potential confounders. So just giving you a brief idea how the sample looked. The average age of our sample was, we had over 4,500 participants, so we had like really large sample. So average age in this analysis was 61 years old, over 58% was women, over 80% were white, at least 60% of the sample were college educated, college graduate. Average sample was overweight. There were approximately 0.3% people had morbidities, 10% of the sample had depression, 28% of the sample reported symptomatic knee osteoarthritis. Symptomatic knee osteoarthritis was defined as presence of radiographic knee wear, that is KL grade greater than or equal to 2, and presence of pain on most of the days in past month over previous year. The average walking speed was 1.3 meters per second, so they were really good. And the number of knee replacements was 9% of the sample had knee replacement over 9 years follow-up. Again, the sample for repeated chair stands was pretty similar. The average time needed to complete 5 times sit-to-stand test was 11.5 seconds. And same, 10% of the sample underwent knee replacements. So now this is my results for the absolute association of walking speed with risk for knee replacement in the overall sample. So if you see, the first row says unadjusted hazard ratio, where I did not adjust for any potential confounders. What I found that walking 0.1 meter per second slower during a 20-meter walk test was associated with 14% increased risk of knee replacement over 9 years. However, when we adjusted our model with potential confounders like age, sex, BMI, race, education, comorbidities, presence of depression and symptomatic knee osteoarthritis, this hazard ratio was not statistically significant and the effect really attenuated. It was like just 1.03, that is 3% increase. So we concluded that walking speed was not associated with knee replacement. Similarly, for repeated chair stands, the first row represents unadjusted hazard ratio, and the second row represents adjusted hazard ratio. And the overall sample, this effect as hazard ratio in the overall sample. If you see, there is no effect of taking more than 1 second to complete 5 times sit-to-stand test. So our hypothesis for AIM-2 were not supported. What I mean by that is walking speed and repeated chair stands was not associated with knee replacement. Kind of counterintuitive to what I thought. I was bummed, like, oh my god, did not find significance. But wait, we are scientists, so we need to find out why didn't we find an association. So plausible hypothesis. Why my hypothesis were not supported? First of all, knee replacement is an elective surgery. So what I mean, not everyone who actually needed knee replacement would have undergone knee replacement. Or maybe there would be people who didn't need knee replacement but would have undergone knee replacement. So we don't know. Second, the expectations for electing knee replacement for younger adults or for middle-aged adults may be to engage in or to participate in demanding level, like to participate in activities on demanding levels. Third, our follow-up, though it's 9-year follow-up, basically it's truncated. Sorry to say that. Because the average time that patients with knee osteoarthritis spend in a non-operative regimen is 13.5 years. And we had 9 years follow-up data. So probably we don't have enough follow-up time. And lastly, when we adjusted our Cox regression model, we found out that the presence of symptomatic knee osteoarthritis explained the association between walking speed and risk for knee replacement. So symptomatic knee osteoarthritis was something which was driving our association. So, however, our study has some limitation. We caution generalizing this study findings to entire world, mainly because our sample was majorly white. They were at least college graduates, so they were like really educated, and average sample was overweight. Then, we did not account for intercurrent events that happened during this 9 years follow-up. That is, people may have had hospitalization, people may die, people may have like any other kind of surgeries. We did not account for any of those intercurrent events. Lastly, our length of follow-up, as mentioned before, was truncated. Now going to my aim 3, where I was interested to see, does it predict death? Why death, right? Well, to your surprise, patients with knee osteoarthritis are 55 to 90% more likely to die than patients without knee osteoarthritis. And this have been proved based on a population studies in UK, China, US. So it's been proved like all over the world. Not all over, but majorly part of the world. But then 55 to 90%, so that's big. Julian Hawker and her co-authors found that adults with knee osteoarthritis who use walking aids like cane and walker have 51% increased risk for all-cause mortality. But so now I want to take this study one level up, because this study did not investigate different aspects of walking difficulty. Because I know there are some people, so I was assisting Meredith with her qualitative study, and what we found out is sometimes people may not use cane because of its visibility, and sometimes people who would not want to use cane, they would still use cane. So I'm like, this is pretty self-reported. So we wanted to quantify walking speed so that we can understand different aspects of walking difficulty. Second, as you all know, knee osteoarthritis just doesn't happen to older adults. It happens even to middle-aged adults. It can happen even to 45 years, like adults age 45 years. So we wanted to see if this association of walking speed with deaths existed in middle-aged adults. Basically, these are the adults aged less than 65 years old and have or are at risk for knee osteoarthritis. Again, very busy slide. Please forgive me for that. So just listen. So this purpose of this aim 3 is to investigate the association of walking speed and repeated chair stands with all-cause mortality in overall sample. And we also wanted to investigate this association when we restrict our sample to middle-aged adults, that is adults aged less than 65 years old. Our next purpose was to identify if there are any thresholds that we can identify that would discriminate people who have higher mortality risk versus those who have lower mortality risk. Hypothesis. So my first hypothesis were like slow walking speed and limited repeated chair stands would be associated with higher risk for deaths. And this same hypothesis would also exist in middle-aged adults, because I think age should not matter. Again, I'm not going to discuss the methods because I've discussed that in aim 1, but my outcome is different. So now my outcome is deaths. So what this means is I quantified time to deaths by months from baseline visit date to the date when they die. The date of death was adjudicated from death certificate or obituary. And again, this study had 9-year follow-up. So someone could have died at 1 year, or someone could have died at 4 years, 5 years. They were dying across different times. To investigate the absolute association of walking speed and repeated chair stands with mortality, again we used Cox regression model, and we calculated hazard ratio and 95% confidence interval adjusted for potential confounders. We repeated the same analysis, restricting our sample to middle-aged adults aged less than 65 years age. To investigate the optimal threshold of this functional vital sign to the mortality risk, we use maximal likelihood chi-square approach. So this is very different than receiver operative curves that is traditionally used to find cut points. The reason we use maximal likelihood chi-square approach is because our outcome was time to deaths. So if we use ROC, we miss out this time component and we miss out the censoring. What I mean by censoring is people may have lost to follow-up. We cannot account people who are lost to follow-up as people who die. They should be accounted separately. So this maximal likelihood chi-square approach is an approach which was developed by SEMA And she kind of like basically used this approach to identify thresholds for time to event kind of outcomes. What happens in this approach is we calculate the chi-square value from a likelihood ratio test using from an unadjusted Cox regression model. This is two statistics, so don't worry. I'm gonna go very brief, but I really love this method. Then we selected a threshold from a model. Like, so we repeated this. We ran like 15 different models for different thresholds of each for each functional virus sign. Then we selected a model that yielded the highest chi-square value. Why we did this? Because this selecting the model that yielded highest chi-square value is equivalent to maximizing the concordance between your exposure and your outcome. It's kind of like optimizing your sensitivity and specificity when you use an ROC curve method. And we use the same approach in overall sample and in middle-aged adults with or at risk of knee osteoarthritis. So my subject characteristics were pretty similar to what I described in AIM-2. But if you see number of deaths, over 6% of our sample died over 9 years. But in middle-aged adults, there were really low deaths. Like, this is what I would expect. Only 3% of the sample died over next 9 years. We found similar results or similar subject characteristics when we use repeated chair stands as our exposure. So going to my regression findings, the row 1 reports the unadjusted hazard ratio and row 2 reports the adjusted hazard ratio. So I'm just going to say the adjusted hazard ratio. What it means that walking 0.1 meter per second slower on a 20 meter walk test would increase someone's risk by 16%, and this risk was statistically significant. We found similar effect when we restricted our sample to middle-aged adults. Now, when we investigated the association of repeated chair stands with the mortality risk, we found that taking 1 meter per second slower on 5 times sit to stand test was associated with higher risk, but this risk was not statistically significant when we adjusted our models for all the potential confounders. Therefore, my hypothesis was partially supported. Walking speed was associated with all-cause mortality, but repeated chair stands was not associated with all-cause mortality. So going to optimal thresholds, since repeated chair stands was not associated with all-cause mortality, there's no point to identify thresholds of something which is not a predictor. So we only investigated the thresholds for walking speed that is predictive for mortality. So if you see, my y-axis is a chi-square value, and my x-axis is all the thresholds that I investigated. If you see, 1.2 meters per second yielded highest chi-square value. So what it means that walking 1.2 meters per second slower on a 20 meter walk test is an optimal threshold to identify those who are at higher risk for mortality over 9 years. We found similar results when we restricted our sample to middle-aged adults. Again, 1.2 meters per second yielded the highest chi-square value. So what this means is slow walking speed, but not limited repeated chair stands may signify higher risk for all-cause mortality. Specifically, we found walking slower than 1.2 meters per second on a 20 meter walk test may be an optimal threshold to discriminate those who have versus those who do not have higher risk for mortality. And the same threshold is even applicable for middle-aged adults, that is adults aged between 45 to 65 years of age. So all middle-aged adults, this threshold is important for everyone. So now our findings were kind of consistent with previous studies which were conducted in well-functioning older adults. Plausible mechanisms like why walking speed may be a strong predictor is because if someone has slow walking speed, then they may have impairments in several body systems, such as lower body muscle strength, aerobic capacity, postural control, proprioception. Because walking speed is such a good predictor for poor health outcomes, it is considered as functional vital sign in well-functioning older adults. And based on my study findings, we can say that walking speed should be considered as a functional vital sign even for middle-aged adults with or at risk for knee osteoarthritis. For repeated chair stands, which was not associated with mortality risk. So our findings were consistent with one previous study, which was conducted in community-dwelling older French women, but it was not consistent with other studies that found an association. Why is this so? Because we think that this transfer skill may not be severely affected in this cohort. So a previous study by Matteo Cesavi, he found out that if well-functioning older adults, if they take more than 17 seconds to complete 5 times sit-to-stand test, then they are at higher risk for all-cause mortality. In our sample, less than 7% of the participants met this threshold. Everyone completed, or like 93% of our sample were able to finish 5 times sit-to-stand test in less than 17 seconds. Therefore, we hypothesize that maybe this transfer skill is not severely affected. Lastly, our adjusted model shows that baseline comorbidities predicted all-cause mortality. There are some study limitations. We caution generalizing our study findings to entire population because majority of our sample were white, they were at least college graduate, overweight. Again, in this time, we did not account for intercurrent events such as hospitalization, knee replacement, which occurred during this follow-up. And lastly, we caution generalizing our study findings of walking speed if walking speed is measured over a shorter pathway. So let's say if a walking speed is measured using a 4-meter walk test, probably our thresholds would not be applicable to that test. The reason for that is because the acceleration and the deceleration component of walking speed test is different when someone measures walking speed using a longer distance versus a shorter distance. So conclusion, we think walking speed may be considered as a robust predictor for deaths in adults with or at risk of knee osteoarthritis, and walking less than 1.2 meters per second on a 20-meter walk test may signify higher mortality risk, and healthcare professionals may use walking speed to assess expected health and tailor goals of care for knee OA population. This brings to my aim 4, which was added really after my proposal because I was really interested in studying this. So what happens is, walking speed should be assessed at one time point, but there's also other studies which says we need to have repeated measures because decline in walking speed is also predictive for all-cause mortality. So in this aim, I was interested in investigating walking speed measured at one time point versus repeated measures for all-cause mortality. What I was interested is, we know physical function declines with age and not all decline are uniform. A study done by my advisor in well-functioning older adults showed that some older adults may have a fast decline, some adults may have a moderate decline, while some older adults may not have any decline, or like they may have a slow decline. What he further found that older adults, well-functioning older adults who have fast decline have 90% increased risk for mortality compared to older adults who have slow decline. But we also know that slow walking speed in present is predictive of mortality risk. This brings to my interesting and very lovely 2x2 table. So what I mean by this is, on the scale, we have on one end of the scale, we have adults who have adequate walking speed in present, and they may have not declined over the previous year. I would term these patients as adequate sustainers. And on the far end of the scale, we have adults with knee osteoarthritis who have slow walking speed in present, and they may have declined over the previous year. So these are like, obviously have higher risk for mortality, and these adequate sustainers have lower risk for mortality. Therefore, they are in green and red. But there's other two discordant groups that I was interested in. So this one group is someone who may have slow walking speed in present, but they may have not declined. So people in Asia, normally we walk very slow. I don't know why. Compared to people in US, I don't know why. So we always have slow walking speed, and we have never declined. So are these people, at increased risk of mortality? Because if you see them from a decline perspective, they're not declining. They are like crossed. But if you see from a one-time perspective, they have slow walking speed. So I was interested in what happens with this patient population. And this patient population, I'm terming them as slow sustainers. So adequate decliners. So this is the other group of people who are walking fast, in present, that means they have good walking speed, but they may have declined from the previous walking speed. So these are like very well motivated people. Oh, they were playing like high level sports at high school, and they want to play high level sports even after they graduate from college. Maybe they cannot, but they are really functioning well. So I've defined these people as adequate decliners. Currently, we do not know how this discordant group, that is slow sustainers and adequate decliners, how are they associated with mortality risk. Therefore, the hypothesis for AIM4 was poor sustainers and adequate decliners would have higher risk compared to adequate sustainers. Again, I'm not going to describe the methods for AIM4 because they were similar to AIM1. And my exposure. So AIM4, the exposure was a little different. So what I did is the OAI study measured walking speed at baseline and at 12-month follow-up visit. For purpose of this study, 12-month follow-up visit was considered as an index date. Decline in walking speed was calculated by subtracting walking speed at 12-month follow-up visit, that is the index date, from the baseline visit. Therefore, we had people who had history of meaningful decline if they had declined greater than 0.08 meters per second. We choose this threshold because this threshold is known to be clinically meaningful important difference in adults with or at risk for knee osteoarthritis. Adults with knee osteoarthritis who had declined less than 0.08 meters per second did not have any history of meaningful decline. For the walking speed in present, what we found that adults who walked at least 1.22 meters per second in present had adequate walking speed. Adults with knee osteoarthritis who walked less than 1.22 meters per second on a 20-meter walk test at the index date was said to have slow walking speed in present. Therefore, we formulated this 4-level exposure group where adequate sustainers had walking speed at least 1.22 meters per second in present and did not have any history of decline over a previous year. Second was slow sustainers who also did not have any history of decline over a previous year, but their current walking speed was less than 1.22 meters per second. My third group was adequate decliners who had adequate walking speed in present. That means they walk at least 1.22 meters per second on a 20-meter walk test, but they had history of meaningful decline. And my last group, that is slow decliners, they had poor walking speed at index date, that is at 12 months follow-up, and they also reported history of decline over a previous year. So my statistical analysis to investigate the association of, or just to investigate the mortality rate across this 4 exposure group, we drew Kaplan-Meier curves and calculated a log rank test to investigate the area of separation between the curves. And then to investigate the association of this exposure group with all-cause mortality, again, we calculated hazard ratio and 95% confidence interval from Cox regression adjusted for potential confounders. So again, I'm not going to describe my participant characteristics because they were similar to AIM2, but what is in, and so I'm going to go to my Kaplan-Meier curves. So what it shows that x-axis is all the months, that is time to follow up, and y-axis is my survival probability. So if someone's survival probability is low, that means they have higher risk for mortality. So if you see, slow sustainers and slow decliners who were in red had higher mortality compared to adequate sustainers and adequate decliners. And if you see the areas, the separation between these curves, they were statistically significant because my log rank test was less than 0.01. Now, showing the absolute association of this exposure group with all-cause mortality, adjusted for potential confounders. So on the x-axis are the 4-level exposure group, which is adequate sustainer, slow sustainers, adequate decliners, and slow decliners. On the y-axis is the adjusted hazard ratio and 94% confidence interval. Okay. Okay. Adjusted hazard ratio and 95% confidence interval. This is what you do when your parents are in India and your family is in India. Sorry. They're very excited. Okay. So if you see this, if you see adequate sustainers, of all the adequate sustainers, 5% of the adequate sustainers reported death, and this was our reference group. Now, of all the slow sustainers, 12% reported death over 9 years, and they had 96% increased risk of death compared to adequate sustainers. And this effect was pretty big and statistically significant. Then of all the sample who were determined as adequate decliners, 2.8% died, and this sample and adequate decliners in fact had 43% lower risk for death compared to adequate sustainers. And my last group, that is slow decliners, of all the sample who were determined as slow decliners, 12% of the sample died, and they had 108% higher risk for death compared to adequate sustainers. So my hypothesis was again partially supported because poor sustainers or slow sustainers had higher risk for death compared to adequate sustainers, but adequate decliners did not have higher risk. In fact, they had lower risk for death compared to adequate sustainers. So why is that so? So one reason that we found that why adequate decliners had lower risk for death compared to adequate sustainers is because if you see in this table, adequate decliners started off at walking really fast compared to adequate sustainer 1 year prior to the index date. So this was 1.56 meters per second. So they were really walking fast. So even if they declined, they had meaningful decline, they were still walking really good, kind of like comparable to adequate sustainers. Therefore, one of the reasons why we did not find higher risk but lower risk is because adequate decliners were functioning very good at one time point. So our study findings in fact suggest a potential threshold effect at one time point. So walking speed measured at one time point may be sufficient to gauge mortality rather than measuring repeatedly and keeping track of decline or not decline. This is kind of consistent with my aim 3, where slow walking speed represents impairments in several body systems such as lower body muscle strength, aerobic capacity, postural control, proprioception, and it also restricts daily walking. And our threshold for 1.22 meters per second were kind of consistent with the threshold established by Matteo Cesari, where he said someone who walks less than 1.22 meters per second have difficulty crossing streets using time signals. As usual, some study limitation. We caution generalizing our study findings to the entire US population or even to entire world, just because majority of our sample was white, at least college graduate, and were overweight. As usual, we did not account for intercurrent events such as deaths, such as hospitalization and knee replacement, and there was differential loss to follow. What I mean by that is slow sustainers and slow decliners had higher loss to follow compared to adequate decliners and adequate sustainers. So potential conclusion and clinical implication from this aim is walking slower than 1.22 meters per second on a 20-meter walk test at one time point is sufficient to gauge mortality risk rather than being measured repeatedly. Therefore, walking speed may serve as a health indicator in knee osteoarthritis population. So overall, what I did just in one slide. So we found walking speed is associated with physical inactivity and all-cause mortality, but walking speed is not associated with knee replacement. For repeated chair stands, we found repeated chair stands was associated with physical inactivity, but it was not associated with knee replacement and all-cause mortality. So this dissertation provided preliminary evidence of functional vital signs measured by performance-based measure for OA-related health outcomes. We found out the thresholds on walking speed and repeated chair stands indicative of physical inability to walk at least 6,000 steps per day. These thresholds may aid clinical decision making and may suggest a potential referral to rehabilitation. Second, we found walking speed was a robust predictor for deaths in overall as well as middle-aged adults with or at risk for knee osteoarthritis, and thus walking speed may be a simple indicator of health and can be used to tailor a goal of care. Lastly, we found that walking speed at one time point is sufficient to gauge mortality risk. Future directions. What I want to do next, or how this study can be improved. So one thing is we want to establish the validity and generalizability of the thresholds that I investigated in this OAI study. And this can be done by investigating the thresholds in a population-based study where we have greater representation. We want to do that because it can establish the validity and generalizability. Maybe it can be applied to everyone. Second, we want a future study should investigate the role of psychosocial factors that may mediate or moderate the relationship between physical function and OA-related health outcomes. These are my references. I promised you, yeah, well within the time. So I would like to thank my funding sources. So funding sources from University of Delaware, American College of Rheumatology, and National Institute of Health. This dissertation would not have been possible without OAI dataset. So huge thank you to OAI study team who made this data publicly available. This dissertation would not have been possible. My committee members, without which this proposal or this dissertation would not have been meaningful, would not have a lot of scientific promise. So thank you for helping me. My advisor, Dan, we had a very interesting relationship being his first PhD student. I've cried, I've laughed, had a roller coaster ride with him, and I'm thankful for teaching me valuable life lessons, research lessons, and how to back off when I have to. Very important lesson. Dr. Snyder-Mackler for always believing in me, for giving me an opportunity to TA in my last time, my dream, and for believing me that I'm a physical therapist too. So thank you so much. Valuing my PT license, so thank you so much. Dr. Hicks for telling me how to make my story more powerful. 3 days before my proposal, I sat with him, and it was like a eureka moment for me. And I'm like, yes, I had everything in my mind. He told me, Hiral, you have everything in your mind, just say it. Don't be scared. So thank you so much. My proposal would not have been better without our 1.5 hour conversation that I had. Thank you so much. Mike, like Dr. Rav Ali, huge thank you to him for supporting me, for convincing Dan to do maximal likelihood chi-square approach, which I used to call brute force method. Really big thank you to Mike for letting me do maximal likelihood chi-square approach and not traditional ROC method. Big thank you to Mike. Dr. Monica Malley, huge thank you to her. OA-related health outcome was her suggestion. I previously had OA-related adverse health outcome. A very nice suggestion by her that she said, Hiral, this is OA-related health outcome, not adverse health outcome. Knee replacement should not be looked as adverse health outcome because it's surgery. You can't term it as adverse health outcome. So big thank you to Monica Malley for teaching me intricacies of physical function and OA and giving me a valuable feedback on my proposal. Big thank you. My lab, very interesting lab. We talk a lot, we speak a lot. We not only talk about our research, but we talk about our life. We share everything. Big thank you. I want to show this Erupt logo that we made, which never went through anything because of the university policy. But I'm like, this is my dissertation. I can flaunt our logo. So this is our logo that we had made, which I'm really proud of. We made this logo when we were in California on the beach. So I love this logo. I'm very attached to this logo. Hopefully one day it will be used somewhere. Lab, thank you Dan for letting me create a lab website. Really appreciate it. I really appreciate it for letting me do that. Dan is a photographer, so this is what we do when he clicks photos. We don't take it seriously. Then all of my lab is really like fitness enthusiastic. We can do yoga even on the beach. That's what we are. All my lab members, specifically Dan, huge CrossFit lover. Louise, she's been like, I can say, a very instrumental person in me completing my dissertation. Without her, it would not have been possible. So big thank you to Louise. Thank you so much for always talking with me and being with me and supporting me. Meredith, Dana, Jason, you guys have been great. Can't explain anything more. Thank you for frequent idea bouncing session or talking me through before I talk with Dan, if I'm making sense or I'm not making sense. Thank you for all your encouragement and support. Sorry. Like Laura, big thank you to you for Bowman's data, like big thank you, like for letting me part of clinical team in some part and for helping us in randomized controlled clinical trial. Big thank you to her. I've not presented a study of my randomized clinical trial because of time constraints, but that study is really important to me. All the DPT students and undergrad summer scholars, Grace is here. Big thank you to them. They have been instrumental helping me, have taught me how to mentor someone. I hope I'm doing a good job. All the past members, Evan, Josh, Melissa, have been great. And Ben, he's not part of our team, but I kind of like have talked with him a lot about machine learning approaches, what I'm kind of interested in. So big thank you to him. Oh yeah, this is a big thank you to all my family, friends, mentors from all over the world. Like, I have a lot of people to thank, so just hang on. So big thank you to all the biome students, postdocs in the department. Big thank you to them. Big thank you to my roommate, my first roommate who has been in US, so Divina. My ACR ARP team who actually invited me and took me on their team where all the senior members were there. I was very intimidating organizing annual meeting conference, but they were like really good to me, really helped me do a lot of services. So big thank you to ACR and ARP. My mentors in Texas, they are a huge role in me being a researcher. They're really sweet and they have taught me a lot. So big thank you to my mentors in Texas. Big thank you to my mentors in India. Oh my God, I can't name everyone, but a big thank you. Then graduate office in OISS and Biomes department. Thank you for giving me opportunities to do all extracurricular activities like grad ambassador, graduate student government, international student advisory committee, Biomes United coordinator, and the list goes on. So thank you for giving me all those opportunities and keeping me sane. I'm kind of like a very little weird person, so fine. Big thank you to my friends for making me do Ohio. First time I'm doing Ohio, so thank you for making me part of the O of Ohio. Big thank you. This is like a bachelorette party that we did for Louise. My first very interesting encounter that I can't share publicly. Sorry. Okay. Then my friends, my family, thank you for supporting me, for not doing traditional arranged marriage and for letting me do PhD. Big thank you to them. Big thank you. Thank you so much if they're listening, I don't know, but thank you to them. My friends in India who have always been with me every single time. My friend, Saurabhi and Piyush, who have been a big support over here. Piyush especially, thank you for being a cameraman. Didn't do a great job, but thank you. And yeah, and thank you to all the mentors from all different countries that I've had. Hoping to add more countries to my list. Want to explore more worldwide. So thank you so much, everyone. I really appreciate everyone. Ohio. Any questions?
So, Hiral, I did have a question about aim 3, I think it is. Hold on. So, no, yeah, it was definitely, it was aim 3.
Okay.
Might have been some of the others, but you essentially set your, go to where the repeated chair stands weren't significant. So, my one question is, what if you'd gone longer than a second? Like, why? You have a
Yes.
rationale in the walking speed for what your interval is.
Yes.
0.8 to 1, right?
Yeah.
Meter per second, but here, it might just be that the interval's too short. So,
That's a great question.
you know,
Yeah.
you might,
I can think of doing, and I can go back and run the analysis by doing 3.4 seconds because that's the MDC for repeated chair stands, and probably I can do 3.4 seconds.
and then if you turned out that they did change by that amount, then I just think just picking the 1 second while it's convenient might not actually be anchored in.
Well, Hiral, is that 1 second change in their performance?
Yeah, 1
Or
second increase.
in a single person's
Within
performance?
Yes.
between person.
Or over time, so those repeated chair stands at 2 different times?
No,
No,
this is the one.
one
This
time.
is the one time.
So
point.
1 second increase in performing 5 times sit to stand test was not associated with all cause mortality.
That's just within a cross-sectional,
Right.
the people who were doing it. I'm
Yeah.
just trying to think about what that, because she's seeing it a little trend here. I just don't know that if you went to a bigger interval, that it wouldn't actually be meaningful. That's all.
Yeah, and that's a great question. I can test the MDC value for sit to stand and then see what how my results pan out.
You did the 12 seconds? Above
This
the
is just
12?
absolute. I did not investigate the thresholds because I did not find the association. So I did not investigate the thresholds for this. And also thresholds in the literature predictive for all-cause mortality was 17 seconds, and I was like, there's no way I can go up to 17 seconds because my sample was really well functioning. But that's a great point, and I can go back and look at it. Yes.
Thank you, Hiral, for a great presentation, and I'm really impressed how you handled all the technical issues too. So
I know.
good use now with humor too. My question is, and that might be because I don't really understand these kind of data and things too, but you're looking at the NEOA population or the whole
Yes.
study. But do you think this is very specific for NEOA, or is it just for anybody?
No,
You know
this
what I
is-
mean? Are these things so specific for that population, or with other data, are they similar to anybody?
So if I understand the question correctly, Dr. Silbernagel is asking if this population is only specific to knee osteoarthritis or is it like applicable to anybody?
Yeah.
So to answer your question, this is only specific to people who have or are at risk for knee osteoarthritis. So probably if we can only be applicable to people who at least have one risk factor for knee osteoarthritis. That's maybe overweight or maybe previous injury of surgery. So it's not for anybody and everybody.
But is there data looking at the walking speed and those things for people that don't have NEOA?
So there's a
Is that
data.
out there, and
Yes.
are those going the same direction? Are they
Yes.
similar?
Yes. So there's a data for walking speed and all-cause mortality in well-functioning older adults. They have done like health ABC and different cohort, like larger cohort study. And they found similar results that walking speed is predictive of death. And Stephanie Studinsky, Middleton, a lot of authors who have been working in this areas over past 20 years.
So how is the NEOA walking speed in reference to the population, this similar sample that doesn't have NEOA? Are the walking speeds and
Yes,
are they similar results or no?
they are similar results.
Okay.
So, because they also found walking speed was predictive for all-cause mortality in older adults, and they established that as functional vital sign. So we wanted to see, can we take that research, what is done in older adults, and can we apply it to knee osteoarthritis? If so, what are the thresholds? And also, if this association exists in middle-aged adults too, because not all adults are old who have knee osteoarthritis. Did I answer your question?
Yeah, I think so.
Yes. Yeah.
This might be obvious to a lot of you, but I'm just an undergrad.
No, any question is welcome.
Cool. Why is education a confounding factor in this?
Great. So education is confounding because what we think is, this is just like, or what previous literature says, like people who are educated, they may be more aware about their health, or they may go to PT more, or they may be better informed about their health compared to people who are less educated, who would not be aware of their functioning status. And also, like they would take better measures to prevent their future health outcomes compared to people who are uneducated. Does that make sense?
Yeah.
Any other questions? Is it like really too good, or was it so bad that no one had any questions?
Great.